the Curious Clinicians, a medical podcast that asks why. I'm Avi Cooper, and I'm joined, as always, by the incredible Hannah Abrams and the amazing Tony Brew. Hello to you both. We have a hot summer evening. It's like true. 94 degrees or something. What temperature is it near?
It's topical.
Yeah, it's 90 here. And Hannah, you were saying earlier there's a heat wave where you are. Is that right?
There is a heat wave where I am. In Seattle, 90 degrees is a heat wave. So it's also 90 here. You may hear my air conditioning in the background.
You may or may not hear it.
Or my fan.
Full blast. So on today's episode, we're going to be discussing the pathophysiology behind a very common and at times severe symptom, though it's admittedly not one that any of us have experienced. And Hannah is going to walk us through the question, why do hot flashes occur? So Hannah, how did you arrive at, asking this question, bringing it to the podcast?
Yeah, it's very topical for the current weather. But I would say if you had asked me what symptoms, physical symptoms, I thought I was going to spend a lot of time thinking about as an oncology fellow, I probably would have said pain, nausea, vomiting, neuropathy. I would not have said hot flashes. And I just didn't realize how much hot flashes come up in oncology treatment. Two of our most epidemiologically common cancers, which are breast cancer and prostate cancer, oftentimes require hormonal treatments that can cause hot flashes. And from talking to people who are on those treatments this year, I have learned that they can be really severe and really life-altering. They can rob people of sleep. They can really just completely alter someone's experience. And so that got me thinking about the idea of what is a hot flash and why would it come on suddenly in the middle of a day and go away spontaneously? If it were like other types of temperature sensation, it would be maybe more responsive to the temperature. Or if it was vagal nerve related, why wouldn't we see other vagal symptoms? So all of that added up to an interesting question to me.
And as you mentioned earlier, I don't think any of the three of us have yet experienced this, but I think we've all seen either family members, friends, or patients who've experienced this. This is like a very, very common experience for certainly in many likelihoods half the population. And just walking around, you're going to see people who are experiencing this. So I'm interested to hear more about like what's going on.
It can be so debilitating. So glad we're going to understand it.
But I certainly didn't have the sense that it was that the intersection with oncology was going to be as great. I thought, you'll see it in your patients who are menopausal, but the idea that you're seeing it as a result of the hormonal therapies, that's kind of news to me. Yeah. But in some ways, I feel like we should start at the beginning. Maybe the definition of a hot flash is like self-evident, but I feel like, I don't know, maybe there's a definition we ought to hear about and some early sense of what's happening mechanistically.
Yeah. So a hot flash is a subset of symptoms of menopause, which are overall called vasomotor symptoms. And I will tell you, they are so common. So it's over 50% of people who are going through menopause globally. They're so common that I had a hard time finding a formal definition. So most research, even if you kind of dig through what's the survey instrument that people in these studies are getting, it just says hot flash.
It's like
you know it if you're having
itself.
it. Yeah. Sometimes it calls them hot flushes, which I thought I had never heard before. But so the National Cancer Institute does actually have a definition, which is a sudden temporary onset of body warmth, flushing, and sweating, often associated with menopause. That feels about like what we colloquially know as a hot flash. They are mediated by vasodilation, and they result in a drop in the core body temperature. And they are very significantly, like we said, associated with health-related quality of life. And they're the most common reason for menopause-related reason for people who are in menopause to go seek healthcare. So I'll say people who have had hot flashes associated with medications have told me they can happen up to every 30 minutes, and that keeps them up through the night. So pretty significant.
So certainly this is an important topic for the podcast. Earlier you had mentioned there are, I guess, a couple of physiologically intriguing features of hot flashes. Like they're different than other temperature related sensation phenomena that we have covered on the podcast before. We've covered chills and a fever, maybe sort of more peripherally related, but like burning with a urinary tract infection. So what is known about the physiology of these events?
All right, buckle in. So this story, so we're going to start at the very top of many of our endocrine pathways, which is the hypothalamus. I'll briefly remind everyone. So the basic format for an endocrine axis is that based on the amount of a circulating hormone, the hypothalamus secretes a releasing hormone to prompt the pituitary to release a stimulating or tropic, sometimes called hormone, which then induces release of the end hormone at the target organ. That hormone then goes back up and provides systemic feedback to the hypothalamus in how much releasing hormone it creates. So hypothalamus, pituitary, end organ. Example we often think of is the hypothalamic-pituitary-adrenal or HPA axis, in which the hypothalamus secretes cortisol-releasing hormone, or CRH, so cortisol-releasing hormone. That prompts the anterior pituitary to release adrenocorticotropic hormone, the tropic hormone, or ACTH. And then that prompts the adrenal to release cortisol, so HPA. The story of hot flashes bring us to the HPG axis, or hypothalamic-pituitary-gonadal axis. And that makes sense when we think about the fact that we're thinking about hormones produced in the ovaries and testes. You might remember from medical school, the basic way that this axis functions is that the pulsatile release of GnRH, or gonadotropin-releasing hormone, causes release of follicle-stimulating hormone, FSH, and luteinizing hormone, LH, FSH, and LH, that then act on the ovaries and the testes to result in release of estrogen, progesterone, and testosterone.
Okay, so that seems pretty straightforward. There's like a sort of a pathway, a three-step pathway. And in the case of that axis that you just mentioned, you've got the pulsatile GnRH from the hypothalamus. That stimulates FSH and LH in the pituitaries. And then this goes on to the ovaries to produce either estrogen or, it goes on to either the ovaries, which produce estrogen and progesterone, or the testes, which produce testosterone. And then there's all this negative feedback from those end organs back to the pituitary and the hypothalamus to decrease GnRH secretion. So that it's complex, but in some ways it's the same pathway that we see in all of these axes, whether it's thyroid, adrenals, or gonadal. So for this particular pathway, is there anything else that we kind of need to know about?
Yes, this is where it gets a little more complicated. So the key thing to know about this axis is the first word you mentioned with the GnRH, which is pulsatile. And so the release of GnRH, or gonadotropin-releasing hormone, has to be pulsatile to put this whole thing together. And I'll warn you in advance, this is where it does get a little bit complicated with a lot of molecules and neurons that our audience may not have heard of before. But we're going to come back to it when we talk about the mechanism of hot flashes and treatments for hot flashes. So that's why we think it's worth it to go into some more detail here. So there are three key neurons that regulate the release of GnRH at the top of this whole pathway, and they're in the hypothalamus. The first neuron is the GnRH neuron. They're all named after what they secrete. So the GnRH neurons secrete GnRH. And then there's two neurons called KISS1 and KNDY neurons. And those are the two neurons that stimulate the GnRH releasing neurons. And they both start with K because they both release a neuropeptide called kisspeptin. So the KISS1 neurons just release kisspeptin that science currently knows about. And the KNDY neurons that's an acronym for kisspeptin, which is the K. And then the two molecules that it uses to actually up and down regulate itself, which are the N and the DY. So N is go, which is neurokinin, and D is stop, which is dynorphin. So in addition to that, so the KISS1 neurons just release kisspeptin, the KNDY neurons release both kisspeptin and these autoregulatory molecules. And in addition to that, the whole thing is negatively regulated on a whole body level by the level of circulating estrogen and progesterone. So to summarize, KISS1 and two neurons, KISS1 and KNDY, stimulate the GnRH neurons to release GnRH. That's regulated locally, so by the KNDY neuron itself, by kisspeptin, which is go, or excuse me, by neurokinin, which is go, and dynorphin, which is stop. And systemically, that's regulated by estrogen and progesterone. So it's upregulated to result in more GnRH release when estrogen is low. Makes sense. You're kind of trying to keep a balance. And it's downregulated to cause less GnRH release when estrogen is high. All of this is going on in the hypothalamus, and specifically the KISS1 neurons are in the preoptic area and the KNDY neurons are in the infundibular nucleus, which I also mentioned because it's involved in the name of the episode tonight. We are going to put a diagram, if you're more of a visual person, into the show notes as well.
Wow. That was actually beautifully explained for an incredibly complicated topic. Tony, I feel like when you said straightforward, that was perhaps a bit premature. But no, Hannah, that was like for such a complicated local and systemic axis, like that was really well explained. And so the way that we get these pulses of GnRH, which seems to be the key to the whole function of this axis, is so you've got this like synaptic contact between these two types of neurons, the KNDY and then the KISS1 neurons. So those two contacting the GnRH neurons and sort of regulating GnRH release. That process is regulated both locally and systemically. And the systemic regulation is via estrogen and progesterone feedback, like all the other ways in which peripheral hormones are going to regulate central stimulation. Okay, got it. So, or I think I got it.
It's a hard thing to get auditorily. So
it is. But what happens when someone gets a hot flash? So this has to be related somehow, right? So
where is the hot flash?
Where is the hot flash?
Yeah, so we'll talk a little bit about what happens to this whole axis in menopause. So in menopause, the ovaries are no longer making as much estrogen and progesterone. So this removes that negative feedback on the KNDY neurons, and that causes them to hypertrophy. And this has been known actually for a long time based on anatomic studies that were done of people's brains who had been in menopause at the time of death. They produce, so these KNDY neurons hypertrophy, and they produce more of the neurokinin B, so that was the go pedal, and less dynorphin, which was the brake. And so that causes a feedback cycle of growth for these KNDY neurons that have the power to stimulate the GnRH neurons. So that means that they also produce more KISS1, which is the thing that stimulates, or kisspeptin, which is the thing that stimulates the GnRH neurons. All that means that they're enlarging. They are contacting and stimulating those GnRH neurons more, which leads to the loss of pulsatility and an overall increase in GnRH, which then leads to an increase in FSH and LH, and then surges in LH are correlated with hot flashes.
Okay, so I think I'm slowly getting this, and I'm slowly getting an understanding of why people don't go into endocrinology. This is hard stuff. This is a lot of complexity here. But from what you've just described, in menopause, we've got the sort of lack of the negative regulation causes growth of these neurons and hypertrophy of everything that's kind of supposed to stimulate the end organ. But it sounds like we've lost that pulsatile nature to it. And so this, to me, it doesn't explain the kind of pulsatile nature in many ways of hot flashes. Like why are those now still intermittent? Like where is that variability? I don't know if this question makes sense.
Yeah,
but like,
where's the flash?
Where's if they're coming on every 30 minutes, this is not a constant phenomenon. Where is the flash?
Yeah, so that's the kicker. That's the kind of interesting thing. And I'll say, unfortunately, this research wasn't all that well funded for a very long time. And so really a lot of this has been worked out in the past decade or so. And so a group of researchers at the University of Washington, led by Stephanie Padilla and Richard Palmiter, had the same question that you had of, okay, so we have some sense of this axis we had for now about 10 years, but where is the intermittency? That doesn't totally make sense. And so at that point, the existing research at the time had identified that there was a susceptibility to LH surges in people who are having hot flashes at baseline in menopause. And it had identified that why that might be enhanced by a hypoestrogenic state, which is to say the growth of these KNDY neurons. But no one had figured out why hot flashes were sporadic. They identified that directly, so this group, Padilla and Palmiter led, identified that directly stimulating these KISS1 neuronal fibers, which they did both chemically and via a laser, could induce a systemic LH surge and a hot flash. They then showed that if you remove the ovaries of mice, it sensitizes them to developing a hot flash, even with a smaller stimulation to those neurons, which they measured by assessing the response to increasing concentrations of a chemical called clozapine N oxide, which is a metabolite of clozapine, which we know has also some effects on this axis. So they were able to sensitize people to these kind of random chemical and, in their case, laser prompts of an LH surge and a hot flash via taking out the ovaries. So they hypothesized that people with hypofunctioning gonads would have KISS1 neurons that were more primed to transient activation for all of those same reasons, with the lack of negative feedback, so the growth of those cells, etc. That means that when some transient minor cue happens, so a high ambient temperature, a heat wave in Seattle, as it were, eating spicy foods, anxiety, altitude, any small physiologic stressor, those neurons would have a lower threshold to fire as a flash, cause an LH surge, and then induce a hot flash. It's also been theorized that people in menopause, for a variety of reasons, may have a lower or a narrow thermoregulatory null zone or euthermic zone. So they might be more sensitive to feeling like thermoregulation is off with a slight increase or decrease in temperature.
I feel like there's this almost like this really elegant, I feel like there's almost this really elegant seesaw balance almost, because like pulsatile GnRH leads to sort of more steady LH secretion, and so, and they don't know hot flash, whereas you lose the pulsatility of the GnRH, then you get these surges of LH, and sort of like, it throws off the balance of that seesaw. I don't know.
And we do get LH surges with ovulation, but they are slower overall than this. And also with ovulation, body temperature goes up.
Right.
And so, yeah, I mean, you're having just the right amount of GnRH, just the right amount of FSH and LH, just the right amount of systemic estrogen. So you kind of see how giving someone a treatment for prostate or breast cancer suddenly kind of loops the cell out of whack.
Right. So it sounds like the theory from this group at University of Washington is that basically if you taking out the gonadal part of this axis, or making that less active, that's where you end up with this sort of central deregulation. Is that sort of a fair summary?
Yeah, and one of the kind of interesting things about it is that any of us could have a hot flash. That's kind of what they showed. If you directly drip this clozapine metabolite into my hypothalamus, I will have a
laser
hot
these.
flash. Yeah, or laser my specific.
Please don't do those things.
Please don't laser.
Yeah, just incredible. Right. So, and what they have done, what people have truly done in healthy volunteers, is injected kisspeptin to people of any sex. And they can measure that an LH surge will ensue. Although I'll say that's also variable through the ovulatory cycle for people who are premenopause. And there's also some sexual dimorphism in response to that based on just the number of kisspeptin neurons that are in the brain via sex. The same is also true of neurokinin B, which is that positive, that was the gas pedal, the positive regulator of the KNDY neurons, which is that if you inject it over 30 minutes in a temperature controlled room in the same phase of the menstrual cycle, people who you inject neurokinin B for 30 minutes are going to develop a significant number of hot flash episodes. So these are kind of some of these cool in vivo experiments to describe that this pathway really does seem to be worked out correctly by that group. And I'll also maybe share two more explanations or two more conditions that are kind of in vivo examples of this. So had either of you guys ever heard of Kalman syndrome in medical school or residency? What did you heard about it?
I definitely remember learning about it in about Kalman syndrome in medical school. I do not recall anything about it at present. It has been quite
Pop
some
quiz.
time.
Wow. I just remember
quite
like
some
the
time since I've done.
anosmia.
Yeah.
Yeah, anosmia. Yeah. So that's so Kalman syndrome, to take a step back, is a genetic condition from that is associated with a variety of genes, where there is failure of the neuronal differentiation and migration into the otic bulb, which is that part of the cranial nerves at the front of our face, right near the hypothalamus. And so, in particular, the GnRH neurons don't migrate from the olfactory bulb into the hypothalamus. And so the result is hyposmia or anosmia, meaning inability or low smell, and delayed or absent puberty. So there's a variety of genes that can cause it. One of them is due to a genetic variant in the KISS-peptin or KISS1 receptor. And very notably, or something that's just super interesting about this, is that people who have a low circulating estrogen because they have Kalman syndrome don't develop hot flashes, despite the fact that they have a low estrogen and progesterone. So that tells us that if you take the GnRH out of the pathway and FSH and LH are low, which they are in people with Kalman syndrome, there won't be hot flashes. So that helps us kind of localize the lesion as being about the GnRH regulation and the ability to mount an LH surge. And then taking a step back, the other situation is when GnRH neurons are normal and the pituitary anatomy is normal, but the whole thing is downregulated. So that's functional hypothalamic amenorrhea, which is a state of secondary amenorrhea that's typically induced by weight loss or stress. And so when that happens, LH pulses are dampened, which is part of why there's no ovulation, and GnRH levels are low. And so also in that scenario, kind of same concept, but lowered, people don't experience hot flashes. And if you give kisspeptin to those people, you can restore LH pulsatility, which kind of underscores the link between what we see with people in menopause.
Okay, so Hannah, we've got Kalman syndrome, we've got functional hypothalamic amenorrhea. Are there any other conditions or situations where either people don't get hot flashes or they do, like, to help us kind of understand like what's going on here? Because I think those are two great examples to demonstrate the importance of GnRH and LH, but there are probably others. And you mentioned earlier that only 50% of menopausal women experience this, so it's not a universal experience.
Yeah, so why some people and not others?
Right.
And a lot of work has been done on this. So a few groups have tried looking into both exposures and genetic determinants of various pieces of this pathway. And so one of the studies that I thought was really interesting is a genome-wide association study that's been done that shows that variation in the gene for the receptor of neurokinin, so neurokinin was the gas pedal, the receptor for neurokinin B is the gene is called TACR3. That variation in that gene is associated with the experience of hot flashes. Probably there are some other genes in the estrogen metabolism pathway that have also been shown to be connected. And I'll say there's probably a lot more to be learned from that might help us work out some of this pathway. But so there's probably some genetic component.
Yeah, that makes sense.
I guess a related question that comes to mind is, some people after they go through menopause, the vasomotor symptoms, the hot flashes, they really stay, right? They don't go away. But for a lot of people, they sort of fade away over the course of, years. I guess I'm wondering why, this is like menopause, like one-way trip. Like, why does that tend, why do some people have it resolve? Like, is there like a rebalancing that happens? in
It's
this
a great
stop-go
question.
stuff?
Yeah, it's a great question to which I do not know the answer. Um, there is more research that should be done about this. Um, I wonder if eventually there is upregulation of some of these receptors in response to or maybe even down, or rather, I should say, I wonder if eventually there's some downregulation of these receptors in the setting of just overabundant kispeptin that results in eventually some of these receptors being desensitized or downregulated. That is not well studied to my knowledge, but it's a great question.
And I guess, some treatments are effective, some treatments are not, right? For vasomotor symptoms and hot flashes. Can you tell us a little bit about how, the treatments that are used interact with this pathway?
Yeah, so there are about as many treatments for hot flashes as there have been civilizations that have allowed people to live to the point of reaching menopause. So I'm going to just briefly cover a couple of them. I will say one of the things that prompted me to finally do this episode was that 2 months ago, while I was on my breast month, the FDA approved the very first neurokinin 3 receptor antagonist for treatment of hot flashes, which is fezolinetant. So that was neurokinin 3 receptor antagonist. So that's a receptor to the gas pedal neurokinin 3 that we've brought up. I will say we don't have any conflict of interest with this drug. In a phase 3 clinical trial, people who were taking this drug went from a baseline of 10 hot flashes a day to 4 via inhibition specifically of the neurokinin pathway. Although I will also note that placebo was also pretty effective, actually, in this study. There's still a delta between those two arms. But overall, it's a really cool idea that blocking neurokinin B, which is this mechanism for auto upregulation of the KNDY neurons, can actually decrease hot flashes.
Were those 4 hot flashes per day less severe than, like, was the severity improved as well, or just the number?
Good question, and I don't know. There's actually 2 big clinical trials, one that was more recent, and I actually don't know if the length or the severity was different. There's a hot flash quality of life or a menstrual symptom related quality of life score that might be in there.
So in the one of the Lancet studies published in 2023, fezolinetant was also associated with a reduction in severity of vasomotor symptoms at 4 weeks. So it looks like duration and severity.
Yeah, so it's super cool, and it's super cool that there's a treatment that's specifically drawn from a relatively recent understanding of that pathway. But we have been treating hot flashes, like I said, since civilizations occurred. So I want to highlight a couple of things that I think our audience might have questions about or may have heard of, or just that I think are interesting. So the first is hormone replacement therapy, which, as you might imagine, is perhaps the most physiologic one. And has been shown to be one of the most effective treatments for hot flashes. And we anticipate that it would work by restoring that baseline negative feedback to KIS1 and KNDY neurons that are stimulating GnRH. Unfortunately, it's not really a good option for our patients with hormone receptor positive breast cancer, where we're really trying to lower the estrogen content. That's why we've given the medication and progesterone. People I at least learned in medical school about using SSRIs or SNRIs for hot flashes, in particular paroxetine and venlafaxine. There has been some of the older literature talked about both serotonin and norepinephrine as being thought to modulate some of this hypothalamic signaling. It's not as rigorously shown or well fleshed out. And I'll also say that in clinical trials of these, there also appears to be a large placebo effect, but there has been some signal that they're effective. And then a very, very wide variety of plant-based compounds have been used over the millennia that people have been treating hot flashes, which include soy, dong quai, and a variety of other phytoestrogens, red clover, and black cohosh. Not as much is published about these. Overall, many of them are thought to work via either being estrogenic or proestrogenic, or via inhibition of serotonin uptake. So I'll link to a few studies on these in the show notes. Unfortunately, a lot of the same concerns are at play, which is that in patients with breast cancer, we really want to avoid anything that is proestrogenic.
So I'm thinking back to episode, or one of our earlier episodes on meperidine, and where we talked about Rigers and the use of meperidine and its effect on kappa opioid receptors. And I wonder, is there any intersection there with hot flashes?
That, yeah. Meperidine always comes up.
Yep.
Um, so I mentioned dynorphin earlier. So dynorphin is the brake, right? To as compared to sort of the opposite of neurokinin. And kappa opioid receptors, I think, have found themselves associated with a variety of symptoms that we wouldn't necessarily otherwise have expected. So dynorphin, that brake, which stimulates the kappa opioid receptor, is the counterregulator to neurokinin B. And it has been shown that kappa opioid agonists can have a small effect on hot flash symptoms, which is thought to be because of that same thing, downregulating the kisspeptin pathway of stimulating GnRH. There's a whole lot of other side effects of these drugs, which is why it's not really logical as a clinical option, but it does tell us a little bit about another piece of that physiologic pathway. Right. And it's also similar to why opioids cause hypothalamic-hypogonadism, which is via decrease in GnRH secretion.
Interesting.
As we sort of, round the corner here, last bit of the episode, I guess I'm wondering too, something that is so pervasive that affects, just so many people so consistently at a specific time of life often, is there some sort of evolutionary basis? Like, is there some reason that that hot flashes are so pervasive?
It's a fantastic question. It does not have a great answer. So I came across some interesting hypotheses about this. One was the idea that maybe there's a need for really close and hormone-responsive thermoregulatory control during the reproductive period. In particular, whether, for example, so there's also a large drop in estrogen and progesterone postpartum. And so one hypothesis that's out there that is not validated was the idea that maybe you need to be warmer in the immediate postpartum period. And so that's a response to a rapid decrease in circulating estrogen and progesterone. Sort of the idea was keep the baby warm. I will say that's not clearly borne out in the available literature. People who are immediately postpartum do experience hot flashes, but are generally not all that much warmer from what I could tell. And other people have hypothesized that it could be, which is cool, a re-equipping of nitric oxide-based vasodilation. So there's a vasodilatory response. Could it be some rebalancing of that system or re-equipping of that system that might mitigate some of the negative cardiovascular effects of menopause? Also unproven, but also an interesting idea.
All right. So I want to hear take-home points, but I feel like we've talked about something called kisspeptin, and you haven't told me and Avi how it got its name. There's KISS1, there's kisspeptin. There has to be some kind of a story there because it's not KIS, it's KISS.
Oh yeah, no, it's named kisspeptin. That's how I remembered it in medical school. It's not just for the acronyms. The answer is that it was discovered in Hershey, Pennsylvania, which is the hometown of Hershey Kisses. Yeah, so that's why. So a fun story behind the name that also reinforces, but it's a unique name for the pathway.
That's pretty cool.
That reminds me of like the alpha-1 like gene variants that we talked about years ago now, right? But sort of where they were, were discovered.
I think we've learned that a lot of stuff just gets named sort of randomly and geographically.
But this is a good one.
Yeah,
reminding you of a Hershey Kiss. All right. Well, with that, Hannah, what are those take-home points?
All right. Yeah. So this is one episode that I know will come up in my day-to-day life again. The first take-home point is that hot flashes are a clinical syndrome of flushing, subjective warm temperature, and a decrease in core body temperature that are associated with conditions that cause low circulating gonadal hormones like menopause or treatment with GnRH agonists. The second point is that decrease in systemic estrogen causes upregulation in the KISS1 and KNDY neurons. This lowers the threshold needed to transiently activate GnRH neurons and generate a short LH surge that generates the hot flash symptoms. And then third is that treatments that alter various points in this pathway have shown some efficacy in treating hot flashes, though I'll say overall that a lot of the mechanisms for many of the treatments are not totally understood yet.
Fantastic. And now I think I finally understand the title of this episode as I go back and look at it. Well, that wraps up another episode of The Curious Clinicians. Thank you, as always, for joining us. Claire Morgan of Notterly.com is our podcast audio editor, and Giancarlo Bonomo is a producer for the show. You can join our mailing list at CuriousClinicians.com to stay up to date on episode releases and have detailed notes delivered directly to your inbox. You can subscribe to our Substack at thecuriousclinicians.substack.com, or you can go to our YouTube channel. Physicians and other healthcare professionals can earn CME and MOC credits from VCU Health just for listening to the episode. For more information, visit ce.vcuhealth.org/curiousclinicians. And as always, the information contained in this episode is for educational and entertainment purposes only and does not constitute medical advice. Until next time, we've been the Curious Clinicians.